We are live.
Good evening, all. Welcome to iFocus Online, episode 320, the 11th in the Back to Basics module. Today, we have with us the very young and dynamic Dr. Pranesh Balasubramaniam from Moorfields Eye Hospital, London, to speak to us on the essentials of ophthalmic physiology, part 1. Dr. Pranesh Balasubramaniam completed his MBBS from the Coimbatore Medical College and has his post-graduation in ophthalmology from Arvind Eye Hospital, Madurai. He's currently a clinical teaching fellow at the Moorfields Eye Hospital. He was an ex-medical officer at Arvind Eye Hospital, Coimbatore. His primary interests include ophthalmic education, which involves teaching to both under and postgraduates, and clinical part involves the deep interest in uveitis. He's a chief educator and founder of King's Cross Ophthalmology Pearls, and he has presented in many conferences, especially on the ophthalmic pedagogy. He is a close-up magician, loves to perform for his friends and family apart from his work. Over to you, sir.
Thank you so much, Shubha, for this wonderful introduction. I thank Santosh Unavasa for this opportunity and his incredible fellows for the hospitality and for the grand introduction. So this is going to be a talk on essentials of ocular physiology. So it's going to be having in two parts. So today will be the part 1, and on Friday we'll have part 2. Now, I understand that you just had a session on essentials of ocular anatomy. So be it anatomy or physiology, it's very difficult to cover the entire spectrum of the ocular anatomy and physio within a span of 4 hours, 2 hours, and 2 hours. It's quite difficult. But what I'll do is I'll try to cover the essentials, that's hence the name essentials, and I will try to focus more towards the exam-oriented questions, because for DNB as well as for MS exams, you have lots of frequently asked questions, especially with regards to physiology of lens, cornea, and aqueous chamber, or the aqueous humor and the anterior chamber aspect of it. So we will take it one by one. Let me share my screen. Great. So hope my slides are visible. Perfect. Okay. As far as the physiology goes, we will try to cover these important areas. First going to be the tear film, cornea, lens, anterior chamber, vitreous, and retina. All these 6 topics are going to be high-yield topics. These are frequently asked questions in exams. So while I'm going to take this class, there may be some overlap with the anatomy part as well. So please don't mind that. Could be a revision or repetition also. So we'll take one by one. And I hope the audience can put their questions in the chat box or in the comment section, and be happy to answer them later on. Right. So like I said, it's very important to understand or know the principles of anatomy before we understand physiology and biochemistry. In the previous lectures by Partho sir of eOphta fame, he might have taken this incredible class on A to Z of anatomy and physiology, anatomy actually. So what I'll do is I won't go this alphabetical order of A to Z in physiology, but rather I will go like from anterior segment to the posterior segment. So today we will try to cover as much as anterior segment as possible, and on Friday we'll go to the posterior segment. Now, I take classes online. I take this on my YouTube channel called King's Crux, which goes by my name, Pranesh Balasubramaniam. And in this, you have this playlist section. You click on this playlist. It goes to this playlist of videos where I have taken both anat and physio combined together, because I try to correlate both along with clinical aspects as well. So it's called, hence the name Bridge Series, connecting the basic sciences with the clinical aspects. So I'll be uploading the further detailed anatomy and physiology videos in this playlist. So please have a watch out on that. All right, moving on to the tear film. So we all know how important tear film is, yet it's so underrated and not much often discussed in our routine clinical practice and routine clinical teaching. But tear film is so very important because all of us are suffering from the lack of tear film or the dryness of disease, thanks to this virtual classes and thanks to chronic or constant digital device exposure. So as far as the tear film is concerned, it's important to know that it is not just going to be the tear film on the cornea, but rather on the tear film over the conjunctiva as well. So we have two components. We have this precorneal tear film, and also we have this preconjunctival tear film. And that's why tear film kind of coats the entire ocular surface, which is evident with the fact that most often you go to a slit lamp examination, you will be focusing, you'll be looking at the tear film meniscus or the tear lake, what you call, which is an important indicator of dry eye disease. So the normal thickness is going to be 1 mm. Okay. So just to show that the tear film is not just unique or not just exclusive for cornea, but also the conjunctiva and the ocular surface as a whole. Some important data which they may ask in exams is that we all know tear film or tear, as you have 98% of water. The thickness is 3 to 4 micrometers. The pH is 6.5 to 7.6. What is more important is going to be this osmolarity. This osmolarity is going to be key because it's just going to be 300 milliosmoles per liter. That's going to be the osmolarity. An increase in this osmolarity or increase in this concentration, what happens? That leads to dry eye disease. We will look later in our lecture how this osmolarity plays a role in causing dryness. But for now, please understand that an increase in osmolarity is going to cause a dry eye disease. So osmolarity is often checked in patients. You take a tear film sample, you take a tear sample, and you test for its osmolarity. What are the functions of the tear film as a whole? As you can see from this picture, the tear film is going to coat the cornea. Okay, and essentially, cornea is going to be avascular. So the oxygen is going to be transferred from the air to the cornea via the tear film. Okay, and not just that, you have aqueous humor, which is going to give the glucose to the cornea as well. So we'll talk about cornea in a minute after this. But the functions being maintaining a smooth refracting surface and helping in the diffusion of oxygen into the cornea, removal of the debris, and more importantly, it protects the ocular surface. Now, during our undergraduate days or even during my post-graduation, the way I learned the layers of tear film or the various aspects of tear film is that there are 3 layers or this 3 tri-layered model which was followed, where you have the superficial lipid, the middle aqueous, and the innermost mucin layer. So a lamb layer is what we call. But these days, we have replaced that to a 2-phase model. There is only a lipid and you have a muco-aqueous phase. So this lipid phase is going to be the same, but rather you see this aqueous and mucus have been combined together to a muco-aqueous phase, right? But please understand, there is going to be still a mucin layer is existing down, but they're not still calling it as a triphasic, but they're maintaining it as a dual phasic or a biphasic model. So in this picture, you can see you have a superficial lipid layer and you have this aqueous layer or the aqueous phase, which has mucin as well. You can see these violet color marks. These are going to be the mucin or what you call secreted mucin. So mucin is going to be secreted into the aqueous, hence the name as muco-aqueous phase. But yet you still have the mucin here as well, which is overlying the conjunctival and the corneal epithelium. So this diagram is important, and I hope this might have been covered from an anatomical point of view in the previous lectures. What I'm going to give you is going to be more of a functional overview of that. Lipid layer is very important. Why? Because you understand that we have water. The water will evaporate when we keep under sun or we keep it open. But you're going to pour a layer of, or you're going to pour some oil on the surface of water. The evaporation is going to kind of get prevented, right? So the lipid layer is going to prevent the evaporation of the water. It's going to maintain a surface tension of the water. Therefore, it prevents the overflow of tears and helps in damage to lid margin. It prevents the excoriation of the lid margin because of tears, because of constant water exposure. A lipid layer will have a hydrophobic and you have hydrophilic bilipid layers. There will be 2 lipids within the single lipid layer. Okay, so please understand this lipid layer is going to be very important in preventing evaporation of tears. And where do we get this lipid layer in the first place? We get that from the meibomian glands. This is going to be the meibomian glands which are present on the upper lid. You have more meibomian glands on the upper lid than on the lower lid. And hence, that's why you have chalazion more commonly seen on the upper lid. It's a common exam question. But relevant to our point is that the meibum is going to be the expressed material. The lipid material is called as a meibum. The meibum has a melting point of 32 to 40 degrees Celsius. And this melting point is increased in this chronic disease or a posterior blepharitis, what we call as a meibomian gland dysfunction, which results in blockage or accumulation of the tears in the gland as well as in these margins, leading on to a very deficient or a dysfunctional release of the meibum onto the eye. So the lipid layer is kind of getting disturbed there. That's why to reduce the melting point, we are applying a hot fomentation or a warm massage on the lid so that you're trying to reduce the melting point. In other words, you're trying to melt all that clogged up or hardened lipid so that you can ease the secretions. So this is going to be an important applied physiology of meibum. Coming to the mucoaqueous layer, the mucoaqueous phase, as the name implies, you have mucus, you have aqueous. So aqueous will focus for now. So previously it was only aqueous phase. Now we are adding mucin because there are some secreted mucin in this layer as well. This aqueous is going to be secreted thanks to the lacrimal glands. You have the main lacrimal gland, you have the accessory lacrimal gland of Cross and Wolfram. In this aqueous phase, you have important elements such as water is going to be the predominant composition, electrolytes, and importantly is going to be the proteins. The proteins are immunoglobulins. You can see there are immunoglobulin A and immunoglobulin E. In certain inflammatory conditions, the IgA is raised, and IgE will be raised in a very important allergic condition called as vernal keratoconjunctivitis. Okay, so we can still test the tear film or test the tears, and you can, if you're going to find a rise in IgE, which means that we're looking at towards an allergic condition, an eosinophilia, more commonly in the eye, occurring as a chronic devastating ocular allergic condition called as VKC or vernal keratoconjunctivitis. Coming to the mucin layer, the mucin layer is going to be a very important component in making sure that the tear film is going to stick on to the conjunctival epithelium. That is an important aspect of the mucin layer. So mucin layer can be either of two types. You have a secreted mucins and you have this membranous mucins. The secreted mucins are going to be in this mucoaqueous phase, whereas the membranous mucins are going to span across the conjunctival and the corneal epithelium. The mucins are going to be derived from the conjunctival goblet cells. So any destruction of conjunctival goblet cells, for example, it could be a cicatricial disease or a vitamin A deficiency. Those two can lead to reduced mucins, thereby leading on to a dry eye disease. And not just that, increased mucins can be seen in, again, allergic conjunctivitis. The mucins are going to give rise to that sticky nature of the tear film. So more of mucins, what happens? You have more of sticky discharge. And in case of bacteria, it's going to be more of a purulent mucin. So the mucins are going to be secreted on an increased number, and their nature or the consistency is going to change depending upon the ocular disease. Now, this is an important concept to understand as far as dry eye disease is concerned. Dry eye disease is going to be a multifactorial disorder. It's quite a complex mechanism, complex pathophysiology it has. And most often they will test you on dry eye disease in your exam. So it's one of the commonly asked questions and high yielding question as well. I'm not going to talk much about dry eye disease, but rather focus or give an applied aspect to the dry eye disease. As you can see here, any irritation, for example, there's going to be a chronic irritation or there's going to be some kind of a dust falling onto the eye. What happens? That's going to stimulate the cranial nerve number 5. The afferent goes back, goes to the brain. Okay, the sensations, the brain senses. So from the superior salivary nucleus, you have the both sympathetic and the parasympathetic impulses are going to come. They're going to go and supply the lacrimal gland via the lacrimal nerve. Therefore, leading on to secretion of tears. This is a very simple, primitive feedback mechanism as far as the reflex tearing is concerned, or reflex lacrimation. Now, what happens in dry eye disease? We have something called as a vicious cycle of dry eye disease. All right. So what happens here is, because of chronic irritation or chronic dryness due to multiple pathologies, for example, a contact lens wear, okay, or any chronic irritant is going to be there on the cornea. Now, it's keep on sending impulses. At one time, what happens, there's going to be this inflammation going to be a huge part in the pathophysiology of dry eye disease. And this inflammatory mediators are going to block or going to disrupt this neural arc. They're going to disrupt this feedback loop. Therefore, what happens? The lacrimal gland will no longer give tears because the impulses are not being properly sent to the lacrimal gland. So when there are no tears, there's going to be more of corneal dryness, more problems, and the vicious cycle is going to continue. This is a vicious cycle, what we expect in case of a dry eye disease because of this disrupted neural arc or disrupted feedback loop, which is quite important. Speaking of tear film, there is one physiological aspect which is again commonly asked in your exam, that's going to be this lacrimal pump mechanism. Okay. Now, please understand this. I told about the importance of this, the tear film margin. So naturally, when the eyes are open, you will have this marginal tear strip and you have a small accumulation of tear at the medial canthus called as the lacrimal lake. So now this lacrimal gland is going to supply the tears, and what this lacrimal pump means is that we are going to study how the tears are going to go into the lacrimal drainage, the lacrimal canaliculi, lacrimal sac, and the nasolacrimal duct. We'll understand that. So what happens when you close the eyes and what happens when you open the eyes? So there are three events which occur on closing the lid. When you close the lid, please remember this previous picture. Have this in mind now. Now, what happens when you close the lid? On closing the lid, there are three events happening. The first event is that there is contraction of the pretarsal part of the orbicularis oculi. Orbicularis oculi is going to be this muscle. You have two parts. You have a pretarsal, you have a preseptal part. The pretarsal part is going to contract, leading on to this compression of this ampulla. Ampulla is nothing but the small dilatation you have here in the canaliculi. So it's compression of ampulla, as a result of which the fluid or the tear is going to be drawn towards the sac. Okay, this is the first event. The second event is that there's going to be contraction of the preseptal part of the orbicularis oculi. Because of this preseptal part of orbicularis oculi, it's going to pull the lacrimal fascia on the lateral wall of the lacrimal sac. It opens up the sac, which was previously collapsed. It opens up the sac. Therefore, the tears going to enter into the lacrimal sac. Then what happens? The third event happens. This inferior portion kind of closes so that air cannot be aspirated into this. So three events, please don't forget this. The first event being the contraction of the pretarsal part, leading on to the fluid getting drawn inside. The second event being the contraction of the preseptal part of the orbicularis oculi, leading on to pulling off this lacrimal fascia and the lateral wall of lacrimal sac, kind of opens up the collapsed sac, and then the tear kind of gets there and stagnates there. There's going to be three events which happen when I'm going to close the lid. Now, what happens when I'm going to open up the lid? Two events happen. On opening up the eyelid, here is the marginal tear strip, right? What happens here is, now there's a relaxation of the pretarsal part of the orbicularis oculi. Now the pretarsal part is going to relax. Therefore, the canaliculi is going to expand and reopen, and this sac is going to collapse. As it collapses, it brings the water down to the nose. So the drainage has happened. And now we're going to resume back. The tear film is going to form, this marginal tear strip is going to form, and you have the accumulation of lacrimal lac here, or the lacrimal lake. So far it's clear. So the two events which happen on opening lid is going to be relaxation of the pretarsal part and the collapsing of the lacrimal sac. And now we are back to square one. So in exams, they will ask you to explain lacrimal pump mechanism. So please write these three events which happens on closing and two events which happen on opening the eyelids. Okay. We finished the tear film part. Now moving on to the cornea. So in cornea, we'll look at biochemistry, physiology, and some important clinical correlates of cornea. Biochemistry is that I just discussed the importance of the tear film, which is going to be an important refracting surface and also helps in diffusion of oxygen from the air into the cornea. And not that, aqueous humor is going to give glucose to the cornea as well. So cornea is going to be an avascular structure. It doesn't have its own nutrient supply. So it derives nutrition from oxygen and glucose from air and the aqueous respectively. This is an important diagram. We will try to compare this diagram again and again. 78% of cornea is going to be water. So you can see the water is going to be in a state of, the cornea is going to be in a state of relative dehydration. Like your lens, cornea should also be in a state of relative dehydration to maintain the clarity. As you can see, in many aspects, water will be a villain. More of water entering inside the cornea or the lens is going to cause problems. The metabolism or the biochemistry part in cornea is not very often asked. Most often, they're going to focus towards the metabolism of glucose in the lens. In cornea, it's all about the physiology or the factors which are contributing to the transparency. Just for completion, the glucose metabolism for cornea, like lens, it's going to be via glycolysis, HMP shunt, and the TCA cycle or the Krebs cycle. As you can see in this picture, glycolysis, what happens by glycolysis, the glucose is going to become pyruvic acid. And this pyruvic acid is going to enter either an aerobic metabolism or an anaerobic metabolism. So both happens in cornea. Now what happens when it's going to be anaerobic metabolism is happening, it's going to be accumulation of this lactic acid. Especially in contact lens wearers, overnight contact lens wearers, what happens is going to be accumulation of this lactic acid. And accumulation of lactic acid is going to cause a corneal edema in these patients, so which is an important clinical correlate. So in exams, when you are writing any anatomy or a physiology related answer, please make sure that you write the applied aspect as well. You can put like a separate box. You can just kind of mention the important relevance. The reason why we don't read anatomy and physio is because we think it is not really applied. We really prefer to learn clinical ophthalmology than these basic sciences. That's for a reason, because that doesn't really help us much. But rather, when we really take interest in read, you'll uncover lots of new things. Whatever clinical knowledge we have gained, you will always find there is an anatomical or a physiological correlation. So that's true with the biochemistry part. Now, moving on to a very important physiology of the cornea. As far as physiology is concerned, I'm going to give you three important concepts. First, going to be the transparency and what are the anatomical factors which are leading on to the transparency of the cornea, the physiological factors which are responsible for the transparency of the cornea, and importantly, the response to injury. The response to injury is very important from a pathological point of view. Okay. What are the anatomical factors for transparency? Again, I want to give you one more tip. In your exams, please make sure that you draw these kind of diagrams. For anatomy, it's obvious that you will be drawing diagrams, but for physiology, you will start writing a lot. But resist the temptation of writing much, but rather you're going to put these diagrams. So this is much effective way of explaining the anatomical factors than writing points and explain things about. So the examiner is going to just look at this picture and he's going to understand that you know what you're writing. So this is a better way of putting across information on the exam paper. So what are the 6 factors which causes, or the 6 anatomical factors which lead to the transparency of the lens? The first is going to be the clarity of the tear film. The tear film clarity is going to be one important factor, because I said when you have more osmolarity of the tear film, okay, more osmolarity, more concentration, what happens that can draw water out of it. Okay, sometimes the opposite can also happen. You can have more water inside. So no matter what the problem lies, maintaining a clarity of the tear film is very important. Second is going to be the homogeneous refractive index of the epithelium. Third is going to be the tight intercellular junctions of the epithelium, the avascularity nature of the cornea, the typical peculiar arrangement of collagenous lamellae in the stroma, and lastly, the keratocytes and the corneal crystallines. So all these 6 factors are going to contribute for the transparency from an anatomical standpoint. Now, just few words regarding each. Now, what is more important is going to be this collagen lamellae in the stroma. A brief overview of the anatomy. In stroma of the cornea, you have the collagenous lamellae and you have the interspersed keratocytes. All of them are going to be mixed in this cement material called as glycosaminoglycans, or the ground substance. Now, what Morris lattice theory states is this. This arrangement of stromal lamella is very important, because you can see in this picture, there is a difference between cornea and the scleral stromal lamella arrangement. Both cornea and sclera have very similar picture. They have a very similar collagen composition, but cornea is transparent, but sclera is going to be opaque. Why? Now, the reason why cornea is transparent is because of the regular arrangement in lattice pattern. And you can see from this picture that on taking cross section, all these individual fibers are going to be equally spaced. They maintain this geometric alignment. Okay, they are equally spaced and they are of equal diameter. So they are separated by less than a wavelength of light. So all these 3 points are important. all these 3 points are going to contribute for the transparency of the cornea. Okay. But on the other hand, what happens in sclera? You see the sclera is going to have an increased separation. You see the arrangement is one is large, one is small, and each one of are kind of separated by very distances. Now, this haphazard way of putting things, or this haphazard way of arrangement of the cornea, the stromal collagen of the sclera, as a result of which what happens, the light is getting scattered off, and that maintains the opacity of the sclera. And that's why cornea is going to be transparent, whereas sclera is going to be opaque only with respect to their arrangement of fibers. Okay. We dealt with the anatomical factors of transparency. Now, moving on to the physiological factors. I just mentioned that the importance of the water inside, because 78% of water, which means the cornea is going to be in a state of relative dehydration. And there are going to be 3 important reasons why the cornea is going to be relatively dehydrated. First, going to be evaporation of water, the stromal pressure, and the barriers and pumps. These 3 are going to be important concepts on this. As you can see in this picture, evaporation of the water and the stromal pressure in the stroma, hence the name stromal pressure, and presence of these barriers, both epithelial and endothelial barriers, and the pumps on the endothelium. All these things are going to make sure that no more water is entering the corneal stroma, and also facilitating water to go out of the cornea. This evaporation of water is quite important from a clinical perspective. As I said some time back, the hypertonic or a high osmolar tear film, a tear film which has more concentration, is going to draw water from the cornea, right? Because you have more concentration, less concentration. So water moves from this area of lower concentration of water to area of higher concentration. So what happens here? There's going to be more of water here. There's more of concentration. So going to be less of water here. So what is going to get drawn out? So a hypertonic or a high osmolar tear film is going to draw water from the cornea. That is going to facilitate the corneal clarity by maintaining a relative state of dehydration. Clear? Now, this principle is applied for the dry disease as well. In dry disease, what happens? There's going to be this high hypertonic or high osmolar tear film is going to be there in dry disease. Okay? And that again is going to take more water out of the cornea, and that is going to cause dryness of cornea as well. That's one negative aspect of too much of evaporation, too much of water getting drawn out. On the other hand, in our post-cataract surgeries, we will see patients who have this stromal keratitis or stromal edema. So one of the common treatment what we give them is going to be, we give them sodium chloride. We give a hypertonic solution. We give sodium chloride like Isol 6. We have different brand names. The sodium chloride is what it does, the sodium chloride is going to maintain this hyperosmolar tear film, and it is going to draw out the water. So wherever you have sodium, water likes to go towards the sodium. So more going to be the sodium, more is going to be the water. So therefore, it's going to facilitate reduction of the stromal edema. This is one clinical application of this evaporation of water. I hope I made things clear. The second concept is the importance of this imbibition pressure. Imbibition pressure is nothing but the product of or subtraction of the intraocular pressure, the stromal pressure. I said the stromal pressure is going to be that pressure which is within the stroma, which is going to facilitate, which is going to keep the cornea relatively dehydrated. The stromal pressure is going to be facilitated or it happens because of the glycosaminoglycans. Okay? The normal stromal pressure is going to be 60 mm. This imbibition pressure is here. Now what happens? The IOP, as long as IOP is well under control, there is not going to be water getting into the cornea. But what happens when you have a rise in IOP? Now, the normal imbibition pressure is going to be minus 40 because stromal pressure is going to be 60. So IOP say the normal is going to be 20. Then minus stromal is going to be 60. So minus 40 is going to be the normal imbibition, which is important to keep the cornea dehydrated relatively. Now, what happens when the IOP has got an I? Now, IOP is 50. Now, what happens in imbibition pressure? IOP is 50. Now, we have the stromal pressure 60. It's going to be minus 10. So there's a shift from minus 40 to minus 10, which is still an increase, right? An increase in the imbibition pressure is going to lead on to water getting drawn inside. Very important. More of imbibition pressure, the water gets drawn inside, leading on to corneal edema. Another important clinical correlation. Why do you have corneal edema in glaucoma? It's because of this. So we finished the evaporation part. We discussed about the stromal pressure as well. Now moving on to the barriers and epithelial pumps. Just talk about the endothelial pump mechanism. Here's a stroma of the cornea. This is going to be the endothelial cell. This is going to be the anterior chamber. Now we can see here, what we want is we want the sodium to go out. We want sodium to go to the anterior chamber or the aqueous humor. When sodium goes out, the water also follows the sodium. So this is an important clinical correlate. Wherever you will see, be it in lens, also you will see that sodium should go out so that the water can follow along with it. And that's why the sodium potassium ATPase pump in endothelial cell is very crucial to make sure that sodium gets out, as a result of which the water is also drawn out of the stroma. Okay. This is an important table which compares the composition of plasma, vitreous, and the aqueous. The reason why I've put here is, as you can see, since the sodium has got out, you can see a rise in the sodium levels in the aqueous. So you'll have always more sodium in the aqueous, you will have less sodium in your cornea as well as in your lens. Now let's talk about the response to the injury. Now you can see here, this is going to be the layers of the cornea. You have the epithelium, Bowman's membrane, stroma, Decimet's membrane, and the endothelium. Now, this epithelium can regenerate. It is essentially which is replaced by the basal epithelial cells and the limbal stem cells, which we'll talk in a minute. So this epithelium will always be replaced. Therefore, when an epithelium is lost, there's not going to be any scarring. But on the contrary, when a Bowman membrane is going to be lost or damaged, it does not regenerate, therefore leading on to scarring, what you call as a nebula. Stroma, again, when there's going to be a stromal injury, again, the keratocytes inside, they're going to form a scarring response. And if more than 1/3 of stroma, if only 1/3 of stroma is going to be involved in the injury, it's going to form the macular grade scar. But more than half of stroma is involved, it's going to form the leukoma grade scar. Please understand that. That's enough. The Decimet's membrane, on the other hand, is going to regenerate. Unlike your Bowman, a bow, when broken, cannot regenerate, cannot be brought back, right? So a Bowman's membrane, once gone, is gone, whereas a Decimet's membrane is essentially secreted by the endothelium. So a Decimet membrane will regenerate. Okay, and endothelium, again, when it's damaged, it will not undergo any repair, but rather will go for two compensatory mechanisms. One is going to be polymegathism and the pleomorphism. We'll discuss that again. Now let's talk about the epithelial injury. That's where the limbal stem cells come into play. This is going to be the limbus, which has the palisades of Vogt. The palisades of Vogt are nothing but these crescents, the small crescents on the epithelium, on the limbal epithelium, where you have this multiple limbal stem cells. So the palisades of Vogt is going to harbor the stem cells. Say you have an epithelial injury. Now what happens? The stem cells are going to come from here. They're going to become a transient amplifying cell. Please understand, the stem cells are not only going to be in the limbal palisades of Vogt. You also have stem cells at the basal epithelial cells of your cornea. Right? So the basal epithelial cells are going to be here. Okay. And they are also going to go up and they will try to replace the lost epithelium. Not just that, these limbal stems are going to become transient amplifying cells or TAC cells, and they're going to replace this basal epithelial cell. And some of them will also go directly and they're going to replace the lost superficial epithelial cells. So when they reach this area, this becomes a terminal differentiated cells. That's very important. So remember, the transient amplifying cell and the terminally differentiated cells, the TDC, the term differentiated cells will be the mature cells which are replacing the epithelium, whereas the transient amplifying cell are going to be the transient cells which are going to be converted from the stem cells. Now with stromal injury, what happens? The same concept happens here. You have all the limbal stem cells are going to migrate and they're going to fill in the stromal injury area. and you have these keratocytes which get activated with help of matrix metalloproteinases. Again, they're going to form collagen. They're going to have scarring response in a stromal injury. So you have a stromal injury. Either there can be a scar, and because of inflammation, there's going to be a new vessels forming in the scar, in the stroma, or you can go for a stromal melt. So these are three fates, three end results of stromal injury. What happens in an endothelial injury? Like I said, when the endothelium is lost, the adjacent normal or relatively normal endothelium is going to expand, forming the polymegathism, or these abnormally large endothelial cells. And the abnormal shape of endothelial cells is going to be called as pleomorphism. Just few words about the limbal stem cells. So the palisades of what is here, like I said, these limbal stems are going to become the transient amplifying cells, and they're going to replace the basal epithelial cells, and also they're going to go up to replace the lost epithelial cells, thereby becoming the terminally differentiated cells. Now, this is just going to be the anatomy of epithelium of cornea. As you can see, this basal epithelial cells are going to have this stem cell-like potential. They're going to assist your stem cells at the limbus. Okay. That's why this thing called XYZ hypothesis, again, a favorite exam question, which was proposed by Toft and Friend. Now, X plus Y is equal to Z. So what is X? X is nothing but proliferation of the basal epithelial cells and differentiating into surface epithelial cells. So surface epithelial cells are lost. Okay. So what is X? The proliferation of this basal epithelial cells and differentiating into this surface epithelial cells. That's going to be the X. What is Y? The centripetal movement of the limbal stem cells is going to be Y. What is Z? The loss of the surface epithelial cells, either physiologically or by any damage. So X plus Y is equal to Z, which means the surface epithelial loss should equate the proliferation of these basal epithelial cells and also centripetal movement of the limbal stem cells. So combination of X along with Y will be equal to the loss of surface epithelial cells. I hope things are clear now. It's a very simple concept. So we are finished with the important physiological aspects of cornea. Now moving on to lens. Now lens, you have biochemistry, physiology, and some important clinical correlates. In biochemistry, we will look at glucose metabolism, pump leak theory, and importance of free radicals. The composition of the lens versus composition of the cornea, both are important. As you can see in this comparison picture, there's going to be 66% of water in the lens, but whereas in cornea, it's going to be 78% of water. So both are going to be in a state of relative dehydration, but lens is even more dehydrated. There are 33% of proteins in lens, just 5% of proteins, inclusive of collagen, is going to be here. But the proteins in the lens are going to be very important in maintaining the clarity of the lens. So lens proteins you can classify into water-soluble and water-insoluble proteins. In water-soluble proteins, you have three types. You have alpha, beta, and gamma crystallins. Now, these are very important because they are going to maintain the clarity. So water-soluble proteins are good, of which the alpha crystalline is going to be the largest crystalline, and it prevents denaturation of protein. So please understand this term called denaturation, which is going to be an important key word. When protein gets denatured, it becomes precipitated. Therefore, the transparency of lens is lost, leading on to cataract. The other important type of lens protein is going to be the water-insoluble protein, which has, again, two things. You have urea-soluble and urea-insoluble proteins. The urea-soluble is going to be the cytoskeletal protein, whereas the urea-insoluble is going to be the cell membrane proteins. Okay. Of the cell membrane proteins, the important protein is going to be major intrinsic protein or aquaporin O. So just please remember these important things. Okay. But what is more important is going to be what is the clinical correlation of these things? What is important or what significance of this water soluble and water insoluble? When you have more of water insoluble proteins like these urea soluble, urea insoluble proteins, when you have more of water insoluble proteins, when you have disulfide bonds existing between the water soluble and the water insoluble proteins, you have more of disulfide bonds, which you often see in a brown cataract. Presence of these two is going to cause protein precipitation or denaturation. Adding fuel to the fire will be the reduction in glutathione. So glutathione is a good it's going to be one of the helping factors to maintain corneal transparency. But when you don't have much of glutathione, this again is going to cause protein precipitation, leading on to cataract. Okay. Now let's talk about carbohydrate metabolism or glucose metabolism in cataract, which is again a favorite frequently asked exam question. As you can see in this picture, I've drawn cataract, lens, and anterior chamber. This anterior chamber has aqueous humor, and aqueous humor is going to provide glucose to cornea as well as to the lens, because both cornea and lens are going to be avascular. The glucose in lens is very important because the glucose can enter either by a simple diffusion or by a facilitated diffusion. When you have more of glucose or even less of glucose, that can lead on to cataract. We will see how more of glucose can lead on to cataract from the next upcoming concepts or slides. We have 4 essential pathways. We have glycolysis, Krebs cycle, the pentose pathway or HMP shunt, and the sorbitol pathway. These 4 are going to be the pathways of carbohydrate or glucose metabolism in your lens. Whereas we saw only these 3 in cornea. You can see here, glycolysis, the end product is going to be lactic acid. We saw that lactic acid accumulation can cause corneal edema in corneal metabolism. 80% of glucose enters the glycolysis pathway, but it's not a very productive pathway because you get only 2 ATPs. On the other hand, Krebs cycle, only 5% of glucose is going to enter the Krebs cycle, but it's a very productive path because 36 ATPs are gained. In your exams, it is enough that if you can just reproduce these reactions, whatever I'm putting in the upcoming slides. Okay, don't need to give the entire biochemistry which you learned in your first year of MBBS. This should suffice. Glucose is going to get converted into a glucose 6-phosphate via the hexokinase enzyme, which is going to be the rate limiting step. This glucose 6-phosphate will become 6-phosphogluconate, okay, by the glucose 6-phosphate dehydrogenase enzyme. And this 6-phosphogluconate is going to enter the HMP shunt. Now, this glucose 6-phosphate is going to enter into glycolysis pathway, where it becomes fructose 6-phosphate, pyruvate, and ending up as lactate. This pyruvate then again enters the Krebs cycle. So far it's clear? Okay. Now, these 3 are going to be the normal pathways by which the glucose is going to enter: glycolysis, Krebs cycle, and your HMP shunt. Now, what happens when you have more glucose? For example, when you have more people in the country, what happens? There's going to be poverty, and some of them are going to choose a bad pathway. Some of them end up becoming criminals or antisocial elements. Like that, when you have more of glucose, they try to enter into this sorbitol pathway. The problem with the sorbitol pathway is that when you have more of glucose, that becomes converted into sorbitol with the help of this enzyme called as aldose reductase. And more sorbitol will become fructose with the help of this enzyme called as polyol dehydrogenase. The concept is more of sorbitol, more of fructose is going to draw water inside from the aqueous. So because of the high sugar inside, it wants water. So the water is getting drawn from the anterior chamber into the lens. There's going to be swelling of the lens, disruption of lens fibers leading on to cataract. Okay, so this is an important reaction. Water is going to swell the lens. It's going to disrupt the lens fibers, therefore disturbing the transparency of the lens, leading on to cataract. We have found that some inhibitors of aldose reductase have been studied in prevention or in treating of cataract, but still it's underway. But no matter what it is, the sorbitol pathway is going to be the key pathway which leads to this metabolic or a diabetic cataract, because more glucose in diabetic patients, they lead on to this metabolic cataract where you have earlier lens opacification, cataract. This is going to be the reason why it happens. The pump leak theory is a very important theory, which we will study in a minute, the importance of this. But please understand that you have aqueous here, you have the lens here. Now, the lens has an anterepithelium, there is no postepithelium. A for A, the anterepithelium will have an active transport pumps, whereas the posterior, you have only passive transport. So active transport happens in the front part of the lens or the anterior part of the lens. There's passive transport in the posterior aspect of the lens. So there's going to be pump in the anterior aspect. There's going to be just leaking in the posterior or the passive transport aspect. Now what happens here is that, understand that potassium will enter from the aqueous into the lens, whereas sodium will enter from outside, from the back, and they will exit out through the lens from the front. So sodium goes like this, potassium goes like this. So both sodium and potassium are going to get leaked out. But whereas when it comes to the anterior part of the lens, there's going to be sodium potassium ATPase pump is going to be there, where it gets the sodium out and takes the potassium in. So like I said, sodium should go out of the lens. When sodium goes out, the water also goes out. Sodium and water love each other. Okay, so sodium goes out, the water also goes out. Therefore, the lens is maintained in a state of relative dehydration. Understand? So when you have a problem in this pump, when you have more of sodium accumulation in the lens, more sodium, more water gets into the lens, therefore causing cataract. So more sodium or more sugar, both inside the lens, when they're going to be high in number, water is going to get inside and that's going to cause cataracts. So please understand that. So as you can see here from this picture, the aqueous and lens. So lens has 66% of water, whereas aqueous is 99% of water. But what's more important is in lens, you have more of Ka. Ka means K for potassium, A for amino acids. So more of Ka, but reduced salt. So the lens will have reduction of sodium, reduction of chloride when compared to the aqueous. Reduced to glucose, because when you have more of glucose, you'll have cataract, metabolic cataract. More of glutathione is essential to maintain the transparency of the lens, because glutathione is going to be one of the free radical scavenger, which prevents the oxidative damage. So from this picture, please understand that there should be 66% of water and 33% of proteins, and understand that the lens should have more of Ka, reduced sodium chloride or reduced salt, reduced glucose, and should have more of glutathione. Now, an applied aspect of it. We all know that when you have an acute rise in blood sugar in diabetics, what happens? They will come with this refractive change in power. So when these patients come, we should make sure that we test their blood sugar. And if the blood sugars are high, we don't advise them glasses because there's going to be a transient or a temporary acute myopic shift. So we avoid glasses when you have a high RBS in these patients. Similarly, recent studies have suggested that it's not just going to be the glucose, but also the sodium. So more of salt diet can again cause an increase in refractive index, like how it is getting caused in your sugar cataract as well. So more of refractive index, which means when you have more of sodium or more of glucose, can cause an acute myopic shift, because more of index, more of myopia, more of focus. So it causes an acute myopic shift. Therefore, you avoid glasses when you have a rise in blood sugar, also rise in your sodium level in your blood as well. So to summarize, this is an important picture. In aqueous, there's going to be more of sodium, whereas in your cornea and lens, there's going to be less of sodium. Please understand that. 66% of water is going to be in the lens, whereas 78% of water is going to be in the cornea. So both of them are going to be in a state of relative dehydration. Let's talk a bit about the oxidative damage. This is again a very favorite question from the exam point of view, but you need to know the two things. Who are the heroes and who are the villains? Who cause oxidative damage and who are going to prevent the oxidative damage? So the evils are going to be the free radicals or the reactive oxygen species, glutathione disulfide. Please remember this. Not only glutathione. Reduced glutathione is going to be the savior, whereas a glutathione disulfide is going to be the evil or the oxidative stress. Increased oxygen levels. For example, in hyperbaric therapy, what they give previously in ROP, you might have read that when you have high oxygen is being given to the babies, that leads to a cataract. So increased oxygen levels can also cause oxidative damage to the lens, leading on to cataract. So these three are going to be the evils, whereas the saviors are going to be catalase, ascorbic acid, reduced glutathione, which is going to be the major free radical scavenger, and your superoxide dismutase. So these are going to be the saviors. These are going to be the evils. So please remember that. With that, we'll move to the physiology of the lens. In physiology of the lens, I'm just going to focus on two aspects. One's going to be the lens transparency. Then we'll talk about the two age-related changes. Another favorite exam question is going to be lens transparency, similar to corneal transparency. Just remember these 4 S's. The semi-permeable capsule, the sodium-potassium ATPase pump, which we studied the importance of sodium getting out. the spatial distribution of the lens fibers with its tight junctions, the single layer of anterepithelium. These four S's are going to cause the lens transparency. The two A's, avascularity and the auto-oxidation or the free radical scavengers. Okay, for example, presence of reduced glutathione in the lens. All these two A's are going to cause, along with these four S's, going to contribute towards the lens transparency. Okay. Now, what happens as age progresses? We all know cataract is going to be a physiological process. So what happens as age progresses? What happens to the transparency of the lens? As age goes, there's more light is getting absorbed and it is getting scattered. So light absorption, light scattering. Okay. Along with the age-related increase in the weight and the thickness of the lens, which is going to cause increasing refractory index. Like I said, more sugars, more water inside, more refractive index. Similarly, more weight and thickness of the lens is going to increase the refractive index, causing lenticular myopia or the second sight, which means patients who are going to have an early cataract, they can see things clearly for near, but not for the distance. That's called as the second sight or lenticular myopia. So more light is getting absorbed, light is getting scattered, increase in weight and thickness of the lens. Along with that, it's going to be loss of membrane proteins and aggregation of proteins. So loss of membrane proteins and aggregation or denaturation or precipitation of the lens proteins, where you have more of water insoluble proteins, more of disulfide bonds. So all these things are going to happen, as a result of which is going to be a reduction alpha crystallins, more of insoluble, more of bonds. So these three things are going to cause towards aggregation of proteins, leading on to cataract. Hope I've made things very clear. So that's going to be the age-related changes, which is the basic mechanism of cataractogenesis. So in exams, if you ask about cataractogenesis, please make sure that you put this diagram there. Now talk about accommodation. So accommodation is going to be another important area, because when I mean accommodation, means the patient cannot read well over 40 years of age. There's going to be accommodative weakness, what we call as a presbyopia. So we should know what is going to be the physiological mechanism of accommodation. So basically, there are going to be these four elements which are going to come into play. So I'm going to see a near object. I want the light to get focused onto the retina. So if the ciliary muscle, the zonules, the lens, and the pupil, all these four undergo changes on accommodation. Now, this is what is being proposed by the relaxation theory of Helmholtz, which is another favorite exam question. Now, what happens when you try to accommodate? The ciliary muscle is going to contract. When ciliary muscle contracts, the zonules are going to get slackened up or it gets relaxed. That's what's called relaxation theory. So reduction of the zonules or reduced zonular tension is going to cause increased sphericity of the lens. So the lens sphericity is going to increase, its axial thickness is going to increase. What happens because of the increased sphericity or the increased curvature of the lens is going to increase the power of the lens. Therefore, the light is getting focused onto the retina rather than focusing on back of retina. So the ultimate eventual endpoint is going to be increase in the power of the lens, which causes the light to focus onto the retina. This is a relaxation theory of Helmholtz. So you can put this table in your exams as well. What happens? Ciliary muscle is going to get contracted. The zonular tension is going to get decreased tension or relaxation. The lens becomes more spherical. The lens equatorial diameter is going to get decreased because as it becomes spherical, it becomes more stout. So the diameter is getting decreased. The lens thickness is going to get increased. The central anterior capsule curvature is going to get steepened, whereas posterior capsule curve is going to have a minimal change. So the anterior part has more of steep, whereas posterior part has only less of steep. And finally, and most importantly, the lens diopter power is going to increase. So I think we'll stop here. So in this first part, we discussed about the physiology of tear film, cornea, and the lens. So in the second part, which will happen on Friday, we'll discuss about the aqueous humor dynamics. Then we'll discuss about the important physiological aspects of retina as well. I hope I've made things as clear as possible. It's going to be whatever concepts I've discussed are frequently asked exam questions. So I've picked the frequently asked exam questions from your DNB and your MS question bank. I've explained those topics in detail rather than talking about everything under the sun, which is not relevant for us also. So I think I'll stop it here and over to the team for any further questions on social media and comment section.
Thank you so much, sir, for such an lucid presentation. We have a few questions from the social media portal, sir. Most of them have been duly addressed by you in your presentation. One of the viewers has asked, can you please elaborate on Dua's layer and its clinical importance?
Okay, right. So what I'll do is I'll share one more picture if that's all right.
Sure, sir. Why not?
Are there any other questions apart from this? So while I set this up, I will try to.
Yes, sir. We did have a few questions related to corneal wound epithelial healing, and which have been addressed already on that XYZ hypothesis as well. And one of the viewers has asked if the hydration of the lens and the osmotic imbalance can be explained again with respect to the postprandial sugars.
Right, sure. Good. So that's going to be another question which needs to be answered.
Right. Yes. Yes, sir. Primarily these two questions to be addressed for tonight, sir.
As you can see in this picture, this is a presentation which I made for the anatomy of cornea. So I skipped this because this is supposed to be more physiology part. Dua's layer is quite a controversy, and but yes, it's a great thing of pride for us. So Dua's layer is going to be seen just below this stroma. As you can see in this picture, just below the stroma and just above the Descemet's membrane is going to be this Dua's layer. It's also called a pre-Descemet's layer. It's basically an acellular layer, has type 1 collagen and doesn't extend to the periphery. So actually, Dua's layer doesn't have much of a significance here for us, actually. But there is importance or clinical relevance with related to the DALK. So in DALK, when you inject these bubbles, we put the type 1 bubble, we have a type 2 bubble. The type 1 bubble is between the stroma and the Dua, whereas type 2 bubble is going to be between the Dua and the Descemet's membrane. So exam, if you're going to ask about Dua's layer, you just mention these points. What is going to be the location and its biochemical composition and the clinical significance. You can just put a box, you can put this dark bubble, you can put this picture. I think that should be fine. I hope that answers the question regarding Dua's layer.
Yes, sir.
Now I will kind of redo the topic, which is on the postprandial rise in sugar leading on to an acute fluctuation in your blood sugars. See, the whole concept is this. There should be reduced glucose and reduced salt in the lens. Okay, there should be more of salt in the aqueous. That's the whole philosophy, basically. Now, what happens is that naturally you should have reduced water in the lens, you should have reduced sugar in the lens, and there should be reduced glucose also inside the lens, because you can see it's 6 in the aqueous, it's just only 1 in your lens. So a lens should have these things. I hope this is clear. Now, what happens when you have an acute rise in blood sugar? When you have a rise in blood sugar, what happens? Like I mentioned in the sorbitol pathway, more of glucose in the lens is going to get converted into sorbitol. Sorbitol becomes fructose. So more sugars, they're going to draw water inside. Either you have more sugar or more salt in the lens. So which means more of glucose or more of sodium inside the lens. That's going to increase the concentration of, or it's going to reduce the water. So you mean, you might have remembered from your old biochemistry, when you have more of concentration inside something, the water is going to come into it. So when you have more of sugars, it's going to osmotic, it's going to indraw the water from the aqueous, be it in a high sugar state or in a high salt state as well. And that is going to cause disruption of lens fiber and cataract. This is on a long term. But for a postprandial rise or any acute rise in blood sugar, what happens there is, again, more water comes inside and there's going to be a swelling of the lens, a transient swelling of the lens. So the lens becomes much more thickened. It increases the refractive index. So what happens when you have an increase in refractive index? As you can see here, so you have a more of refractive index. This is going to be the lens. Okay. Now, normally you need to have the light is going to go there. It should fall on the retina. Now, what happens here when the lens becomes even more thicker because of its increase in refractive index? There's going to be myopia, which means the light is going to now fall in front of the retina. So it's an acute myopic shift. So patient will come with a refractive error. The patient will say that I can't see. So you take a refraction, there is going to be some corrections going to be there. But if you test the blood sugar, if the blood sugar is going to be very high, then you should not give glasses for that patient. You should wait. Let the blood sugars control. And then once the blood sugars are going to get controlled, then the transient state of acute myopic shift will be lost. There's going to be emmetropia once again. That's why you should never advise glasses when you have a very high blood sugar. I hope I have answered the question.
Yes, sir. Very well, sir. So we have another question pertaining to the physiology of pupil and its relation to the Horner syndrome. Probably that would be addressed to in the next session of physiology.
Yes. So I will address the pupil Horners. I will do it in the next session. Along with aqueous, pupil, and retina will be the three things. So I thought pupil. I thought I'd keep it in reservation because I presume someone will take this in the neurophthal part. But if you guys want, I can just give a brief description of the pupil physiology. So what exactly has the student asked for? Can you please tell me that so that I can be more relevant to that question for the next class?
Yes, sir. The question pertains to explanation of physiology related to the light-near dissociation, sir.
Okay, right. So he wants that. Okay, light and dissociation. Good. So for Friday's class, I will try to cover the physiology of the retina and the aqueous, because both are quite important chunks of physiology. Then if time permits, I will try to take the pupil aspect with relevance to the light-near dissociation and the Horner syndrome. Is that fine?
Yes, sir. Perfect, sir. Before we conclude for today, I have a small announcement. We meet next on the 14th of July for the Essentials of Ophthalmic Physiology, Part 2 by Dr. Pranesh himself. And it will be a delight to hear him again. And as he has just mentioned, that he'll be dealing with the physiology of aqueous and retina in the next session.
So you can also put, if you feel that some topics have been missed out, if you think some topics are important to be addressed in the next session, you can still put it in that comment section or the chat box. I think I can still access that later, if I'm not wrong.
Yes, sir. We can put it across to you, sir.
Yeah, sure. Because I think comment sections is always disabled on the iFocus thing. If not, they can get back to the team, and I'll be able to answer those questions.
Sure, sir. Thank you so very much, sir, for your time this evening. Hope to see you on the other side, sir.
Sure. Thank you so much. Thank you, Shubhav. Thank you, Ruju. Thank you, Shafali. And thank you, Santosh, sir, again for the opportunity. See you again soon. Thank you. Take care. Bye-bye.